Okay, welcome everyone. It looks like we are now live. Thank you for joining today's discussion on the 340B program and its impact on patient access. As the nation's oldest consumer watchdog, the National Consumers League seeks to ensure federal policies are working for consumers. Our advocacy calls for increased transparency across the healthcare marketplace. The 340B program has grown from a little-known federal drug discount program to a major source of revenue and controversy. Due to a broad lack of transparency, the extent to which the program is benefiting patients is unclear. That's why we thought it was important to host this discussion and share new research on 340B published by Neil Meja of Health Capital Group and adjunct professor of business and economics at Columbia University. Neil will give us an overview of his findings and followed by a panel discussion with Ted Ocon of the Community Oncology Alliance and G. Bai of Johns Hopkins Bloomberg School of Public Health. But to set the stage for today's discussion, I'd like to introduce my colleague, Sally Greenberg, Executive Director of NCL, for a few words.
Yeah, thank you so much, Jeanette, and welcome everyone. My name is Sally Greenberg and I'm Director of the National Consumers League. I'm just going to give an overview of our position on 340B and give some background, but you've got a lot of experts here, so we're looking forward to a very vibrant discussion this afternoon. So the once little-known 340B drug discount program has grown in size and prominence over the past decade. Today, it is frequently the subject of policy debate and scrutiny, even to the point that President Biden has referenced the program in recent remarks on prescription drug costs. Congress created the 340B drug discount program in 1992, requiring that drug manufacturers who participate in Medicaid provide outpatient prescription medications at significant discounts to eligible covered entities defined in the original statute. Congress intended that the program support uninsured and vulnerable patients' access to medicines and care. However, hospitals are not required to pass along 340B discounts to patients and are not required to reinvest the profits from the 340B program into care for low-income populations. Government stakeholders, like the Inspector General's Office of HHS and the House Energy and Commerce Committee, have raised concerns about this lack of transparency, raising very legitimate issues about the program's ability to fulfill its mission. Following the passage of the Affordable Care Act, the Health Resources and Services Administration, otherwise known as HRSA, issued regulatory guidance allowing covered entities to contract with third-party contract pharmacies to sell 340B drugs to patients. In the ensuing years, contract pharmacy growth has far outpaced overall program growth. And while HRSA's action was intended to help small providers lacking in-house pharmacies, contract pharmacies have become profit centers for large hospital systems and publicly traded chain pharmacies. Evidence indicates that even low-income, uninsured patients may be charged the full rate for their medications at the contract pharmacy counter. Given the ongoing and controversial expansion of 340B and the lack of transparency and accountability in the program, we very much need additional research that examines the extent to which patients and healthcare consumers are actually benefiting or not benefiting from 340B discounts, as Congress intended. As strong advocates for the vulnerable patients for whom the program was envisioned, the National Consumers League is pleased today to join Neil Meja in this discussion to share his results of a white paper on the topic that he wrote. And Neil's going to help shine a light on the share of the 340B profits that are reaching patients versus ending up in the coffers of for-profit chain pharmacies and large hospital systems, and the degree to which 340B is or is not contributing to hospital charity care. We're so glad to have all of you with us today, and I'm going to pass it along to Jet to lead us through the rest of our discussion. Thanks, everyone.
Thank you, Sally. We're excited to hear from you. We look forward to hearing directly from you, Neil. The floor is yours.
Great, thanks, Jet, and thanks, Sally, for the introduction. I know they're getting the slides going, I think. Hopefully, there we go. So I'm excited. This is my second 340B event of the day, which would suggest there's a tremendous amount of interest in 340B. I will say that when I teach at Columbia, I teach a health policy course, and the single longest setup lecture of all is the 340B lecture, simply because it's such a convoluted program. And especially for those that are uninitiated into the program, it just takes a lot of times through it before you really understand, is this a federal program? Who's paying for this program? All of those details, very complex. I think that's because over the last 30 years, since the program started, it has really evolved in terms of size and has probably outgrown its sort of original regulatory structure. And so it's led to a lot of questions about whether the program itself is reaching patients, in what proportion to the size of the program, et cetera, et cetera. So the idea behind this work, and maybe you can go to the next slide, is just building on some prior work that I've done that estimated the overall size of the program. We wanted to understand better, how do those program profits get distributed throughout the system, right? So that original work, which I published maybe 6 or 7 months ago, maybe it was a little longer, I had pulled data through a FOIA request to try to get a better handle on what kinds of drugs are being sold in the program, which therapeutic areas and where, and we published that work. The size of the program profits we got in that study were about 40.5 billion. And so by profits, we're really defining that as the difference between the reimbursement value of the drugs and the price at which the covered entities are acquiring the drugs. Pretty simple definition. Since then, I think others have published very similar looking estimates. So there are different ways you could try to calculate it. But we're talking about a program that is roughly on the order of probably 80 to billion-ish of reimbursement value in 2019, yielding something like $40.5 billion in profit. And since 2019, obviously, all of these numbers have inflated a little bit more over the last 2 years. I think, estimates I've seen something like 20-ish percent, 25% program growth a year, and faster than that for the contract pharmacy portion. And what the idea of this study is, and if you can go to the next slide, is really to try to pick apart where do these profits go. There's really 4 places they could go. One place they could go is to the contract pharmacies themselves. Clearly, they do earn profit from participating in this program. I estimated somewhere between $5 and $7 billion of profit is in effect retained by the contract pharmacies. That was in 2019. Again, that number would have grown since then. That's their share, for administering whatever amount of drugs are going through. The second place that profits might go would be to the hospitals themselves in the form of retained profits. And by that, I mean, 340B is presumably increasing the profits for the participating hospitals. And we don't know, we can make an estimate for how much of those are getting distributed to patients by looking at the cost reports and financial statements of the hospitals, which is what we're doing in this study. And to cut to the punchline, what we find is that when you control for the other factors that drive hospital profitability, so for example, is the hospital in a chain, and what's its payer mix and teaching status and all those kinds of things, you can see all the details in the paper itself. You do find a statistically significant impact on hospital operating margins for participating in 340B, and the direction of that is positive. And roughly speaking, holding all other things constant, you get a number like a 2.7 percentage point increase in hospital operating profits in 2019, again, in 2019. And about 1.1% of that, so 1.1 out of that 2.7% is attributable when you add in the contract pharmacy participation into the mix of those regressions. And we're not going to go into those in gory detail because we only have 15 or 20 minutes, but I encourage you to look at the paper. When you look at the typical amount of participation and the size of the typical participant, you get a number of $17.7 billion in 340B profits that are in effect increasing the total operating profits of those hospitals. Third place that the profits might go would be through the grantees. And we do estimate, consistent with other folks, maybe something like 10 or $12 billion of 340B activity is happening through the grantees. Because it's not very transparent, we don't really know exactly how those funds are used. We know that a lot of those funds are used by the grantees to fund their activities, but we don't know the detailed nature of that. So we don't know how much of that is, let's say, winding up staying with the contract pharmacies versus winding up in the hands of the grantees. And then when they're in the grantees, what is it used for? We know there are lots of examples of it being used for different patient activities, but we don't know the total quantity of that. And then whatever we haven't accounted for in those first three categories, we can assume goes to patients directly, right? And in our case, when we've accounted for those other activities, we're left with something like 20 to 25% of the total $40 billion, so call it 10 to $12 billion, that we do think is making its way to patients in whatever form directly. So on the one hand, when you look at the program, you say, well, that's a very significant amount. On the other hand, you'd say, you know, from an efficiency standpoint, it's nothing close to the total amount. And so we want to understand more about that. And I think there's a research agenda underneath that really will help us do that. To summarize, the parts where we think there might be a patient benefit, we see off to the left. So some share of the 19% that goes through grantees is going to patients. 20 to 25% is presumably going to patients in the form of either discounts or other direct services. But then you see off to the right there, a significant portion we know from this research is not going directly to patients. It may be going in some indirect ways that we're not counting here, but we do think that a very significant portion is staying in the contract pharmacies or bolstering the operating margins of the hospitals themselves. And a significant portion of that, again, is driven by the contract pharmacies. Why don't you go to the next slide and we can, thank you. So I was a little surprised in looking at the raw data on hospital profits, and this is something I know G can talk about more when she's discussing the paper, that even when you don't control for the factors that should be determining hospital profitability, you actually see the operating margins for 340B hospitals are somewhat higher than for non-340B hospitals. And by non-340B here, I mean not-for-profit non-340B hospitals, not counting the for-profit world, which of course is not eligible for 340B. So, and also interesting, if you look down below, almost 80% of hospitals in the program use contract pharmacies. I was surprised that the ones using contract pharmacies are the bigger pharmacies, about 50% bigger on average in terms of revenue than the 340B hospitals who are not taking advantage of contract pharmacy. And so when we talk about contract pharmacy, I think the original way that worked was to kind of expand the reach of smaller hospitals that might not have their own in-house pharmacy. And I think what's happened over time is it's turned into a tool that's used by the bigger hospitals as well as some small hospitals, but bigger hospitals are very active in this space and are expanding their reach far and wide through this contract pharmacy network. Go ahead. When I looked further, I tried to understand, is there some different in like the operating profit growth for 340B hospitals? Maybe the activity through 340B is going up, but maybe it's all being passed through to the patients, in which case the operating margins should stay roughly the same. right? Because in the operating margin, you're accounting for things like charity care and other factors that would help patients directly. So what you see in terms of aggregated profit, partly because there's so many hospitals in 340B, you see that the biggest increase, there was a very large increase in overall profit from 2012 to 2019 amongst the 340B contract pharmacy hospitals, right? Very significant. And if you go to the next slide, you can see the difference between their operating revenue, their aggregate revenue, their aggregate profits, and the amount of charity care they're doing. Because what we're looking for here is to say, if 340B is driving an increase in revenue and profit, it might also be driving an increase in charity care, which is sort of the intent of the program, right? And what we see in this slide, when you look at, this is based on their 2019 status, you see that we included for-profit hospitals here to the left. You see a very large increase. So in 2012, this is just the year before Obamacare is implemented. So you would expect sort of all of the charity care to go down in the first year, which it did. And then over time, it's come back for all of the categories and increased from where it was in 2012, except for the 340B contract pharmacy hospitals, where it is yet to recover. There could be many reasons for that. It could be focused on other things, but it is just a function of the data to see that the hospitals with the 340B hospitals have actually experienced an absolute dollar decline in their charity care. And this is charity care as measured strictly by their charitable direct patient support. It doesn't necessarily include things like, the value of like the Medicaid losses that they experience and other things that might count toward community benefit. That's a topic, again, I know can talk in great detail about. This is just the direct charity care piece, but we do see that it went down significantly here. Go to the next slide, please. So this is just to show you the aggregate numbers. Certainly these hospitals are still doing a lot of charity care, not to take anything away, but we do see that the absolute number has declined when we just add it up this way, in contrast to all of the other categories, including 340B hospitals who don't use contract pharmacies, who have managed an increase in their charity care over the same period. Next slide. So try to unpack this. What we did was we ran also a multivariable regression that controlled for things like chain membership, the uninsured rate, all of the things we control for in the regression where we try to figure out what's happening to operating profits. And what you see here is that in that regression, which again, you can look at in the paper, there's not a negative impact of 340B, but there's no positive impact on the amount of charity care going on, right? In effect, what you find is just statistically insignificant and very close to zero, in fact, slightly negative, but close to zero, effect of 340B participation on the amount of charity care done at the hospital at a per hospital level. So the other things in that regression all had the sort of expected effects, but charity care wasn't affected by 340B. So you have this two-sided coin where on the one hand, somewhat of an increase on operating margins. On the other hand, no measurable increase in the amount of charity care. Again, we're not counting everything, but the amount of charity care seems to be flat. So I would tell that story as potentially one of crowd out. So clearly the hospitals are still doing plenty of charity care, but to the extent that it's being funded by the 340B piece, that would be in effect not additive to their existing charity care, but more of a substitute. So go ahead. And so when you add up the contract pharmacy pieces, what you get out of the paper research, excuse me, is that $5 to $7 billion worth of profit that's being retained directly by the contract pharmacies, and about $6 billion of the retained hospital profits, which are influenced by or being attributable to the contract pharmacy usage. And that comes out of the regression results, that 1.1% number that I mentioned earlier. So about a third of all the hospital profits seem to be driven by this contract pharmacy piece, which I think is consistent with the data we've seen on, for example, just overall volumes running through contract pharmacies. growing very fast, but about a third of the hospital profits and a similar amount that's being kept by the contract pharmacies themselves. So go ahead, one more slide here. The one other piece, and this is research that I'm expanding on now, is I was surprised at the degree to which the contract pharmacies are actually moving into higher income areas and lower uninsured areas, which is, I've seen some other research. I know Avalier just put out something that was very similar in terms of their findings, done in a different way, but a similar result. Just to say that the contract pharmacies are whatever they may be doing for patient access, I think the reason why they're branching out so heavily into these higher income areas is because that's where the patients are and that's where the money is for the contract pharmacies to identify those patients and then to subsequently share those benefits with the covered entities that they have contracts with. So the nature of those relationships between contract pharmacies and the covered entities is a little nebulous. We've seen the GAO had done a study a few years ago saying that somewhere in the order of 15% of the economics go to the contract pharmacies. We don't know what that number really is. We have an estimate here, but that's an area of further research that we're looking at right now. And I think, more to come there. So I think that's my last slide. Is that my last slide? Yeah. So just to reiterate, these are the main points that I've reviewed. About $40.5 billion of overall profit, more than half of which don't seem to go directly to patients. The 340B hospitals using contract pharmacies were the fastest growing in terms of profits. Their charitable care declined in absolute dollar terms. And so this to me and then the contract pharmacy piece that I've mentioned before, I think one of the punchlines here as an economist is this isn't really a costless program for taxpayers. Even though there's no direct taxpayer money being spent, there are a lot of indirect costs. There's the fact that the profits at the hospital level aren't taxed themselves. These are non-taxable entities, so there's a foregone cost for taxpayers there. There's indirect costs to Medicaid that there's been some amount of activity around to the extent that states want to recapture some of those savings for themselves in their state Medicaid programs means that there's foregone costs. We know that 340B has had an impact on provider consolidation. I know Ted can talk a lot about that, and that has some indirect costs. And finally, clearly there are some misaligned incentives on the choice of therapy that have been documented by others, certainly around cancer care, but also other areas. And these are all areas worthy of exploration from policymakers that can be looked at with data. And I think, certainly from the perspective of an economist, there's just a wealth of really interesting questions around 340B. So I appreciate the opportunity to share these results with you and looking forward to the questions.
Great. Thank you so much, Neil. We really appreciate you bringing this and, congratulations on publishing this new research. We look forward to hearing more from you during the panel. Right now, I'd like to welcome our two expert panelists. Ted O'Con is the Executive Director of the Community Oncology Alliance, an organization dedicated to advocating for community oncology practices and the patients they serve. Ted and his organization have established themselves as a leading voice calling for transparency and accountability in the 340B program. Most recently through a report titled Examining Hospital Price Transparency, Drug Profits in the 340B Program. So we're excited to have you join Ted. And we are also joined by Ji Bai, a professor of accounting at Johns Hopkins Carey Business School and professor of health policy and management at Johns Hopkins Bloomberg School of Public Health. Dr. Bai is an expert on healthcare accounting, finance, and policy. She's testified before the House Ways and Means Committee, written for the Wall Street Journal, and published her studies in leading academic journals. Renownedly, she's currently a visiting scholar at the Health and Analysis Division of the Congressional Budget Office. So just a powerhouse of experience here that you two bring to join Neil here in the discussion. But to kick off the the panel discussion. I want to turn to Dr. Bai first. So your research focuses on hospitals. We'd love to hear your thoughts on the rapidly increasing 340B profits. And do you think the white paper's findings align with what you've seen across the industry? So we'd like to hear from you. What does this mean in terms of hospitals' obligation to provide community benefit as well?
Thank you very much, Janet. This white paper really identified some areas that has not been recognized before. And especially, I would emphasize 2 points. The number one is, if we think 340B program as an investment project, right? So as you know, very well framed. So the public and taxpayers are subsidizing the 340B hospitals. If you think about the for-profit hospitals, no, they don't get it. Other non-340B non-profit hospitals, they don't get it. This is substantial amount of subsidy provided by the public, by the taxpayers to help those hospitals. But for what, right? So we know this is an investment, but we want to know the return. So I think Neil's white paper looks into that point. What is the return? And then they focused on this charity care, which is the provision of care to disadvantaged patients without the action to get the bill collected. So it's really a direct reflection of the hospital's activity to advance their charitable mission. But then they found there's no link between this 340B program and the charity care provision. So that really tells us, well, if we look at this as investment, then we put in the money, but we don't get a return, right? In that sense, I think that's a huge contribution. And also from the policy perspective, the policymakers designed the 340B program for a reason, right? It is to help the hospitals, the selected hospitals that provide a lot of service to vulnerable patients. So basically, the policymakers want to subsidize, want to help those hospitals serving vulnerable patients. So we want to see if there's any disconnect, or if there's good connection between the purpose of that program from the policymaker's perspective and the consequence. And again, there is a huge disconnect, right? So we have this great intention, but then the result is we are now seeing more charity care provision for the vulnerable patients. And my research never looked directly at the 340B program, but I would say the result follow the same spirit. We have to, the public and the policymakers and our audience, we have to look at this question from a investment return perspective. The substantial benefits really need a justification. If there's no justification, then it's up to the public to ask why and how we improve and to make the intention and the consequence connected. Otherwise, this rule, I would say, is not fulfilling its purpose. Thank you.
Thank you. Well said. Amazing. So, Ted, I'm going to turn to you next. Your organization has been very involved in this space. So how have you seen the 340B program affect your members and their patients? Particularly our oncology patients seeing an affordability benefit from the rapid growth in 340B profits.
Yeah, Jeanette, well, thank you for having me. I mean, the problem with the 340B program is it is so mutated from its original intent. And the problem is that it does have a direct impact on patients. I can't tell you how many times that a independent community-owned practice will send a patient over to the hospital. The hospital won't treat them, even though the hospital ends up being 340B. So you have to say to yourself, where are these 340B dollars really going? Because unless the patient comes in through the emergency room, of course, they don't have to be treated. And not only that, but we see many cases where hospitals very aggressively go after debt collecting, and inevitably it turns out to be a 340B hospital. So this is a real problem. And I think the thing that comes down to it, I always say that when we talk about drug prices being too high, and we have a problem with drug prices, especially cancer and other specialty drug prices, that it certainly starts with the pharmaceutical companies. No doubt they have a hand in this. But what's remarkable about this now is what these 340B hospitals are making on these drugs. So we had Modal Bioadvisors, Ronnie Gal, do a report for us. It's up on the COA website last year, and looked at roughly 50 cancer drugs and saw and looked at literally the DISH hospitals. As you know, hospitals now have to report their data by payer type. And the average markup of the hospitals that report, and not a lot of hospitals report, about 11% of them report. Why? Because they don't want to show how much money they're making on drugs. And the average markup was 3.8 times. The markup, 3.8 times, not percent, 3.8 times the average markup. The highest markup was 11%. And the lowest markup was over 2 times. 11 times over 2 times. And how that plays out is this, in a real concrete example. Patient comes in and they're on a drug, Darzalex, multiple myeloma, for a year. And if you go into an independent practice and you look at a Medicare patient, that practice literally makes $7,000 a year that, of course, goes towards operating costs and other things like that. The 340B hospital on the Medicare side, it makes double that at $14,000. The commercial patient who comes into the hospital and Darzalex literally is paying a percentage off of $213,000, $7,000, $14,000, $213 on the commercial side. So the problem is, and this was identified in a JAMA study that came out a week ago or so, JAMA said that basically patients, 340B hospitals are in cases making more money than even the drug companies that produce this. So it's a real problem, because when we talk about in this country drug prices, and I saw some more data out about how Americans are fed up with drug prices, they're not talking about the underlying price. They're talking about the cost to them. And the cost to them when they walk into an average 340B hospital is a huge markup over what the hospital is paying for that drug.
Yeah, that's incredible. Well, let's talk now about the growth in contract pharmacy arrangements. This has been a major component of the 340B revenue in the system. And I'm going to go to Neil first on this one. Neil, you've done previous research on this question. Is the expansion of contract pharmacies, both in numbers and geography, benefiting patients?
So the whole program does create benefits for patients. There's no question that there are some patients who benefit. You have over 100,000 contract pharmacy arrangements now, 100,000. In other words, the average entity that's a covered entity has something like 23 or 24 contract pharmacy arrangements, which gives it enormous scope. Some of those are hundreds of miles away. So on the one hand, it certainly must help some patients who, instead of having to take an extra bus trip or something to get a 340B prescription filled, they can go to a local pharmacy, and that has an amount of sense to it. The issue, and what we see in the data as the contract pharmacy network expands so rapidly, and especially into these higher income areas, is that most of the activity cannot be so that we're helping the relatively smaller number of patients who are the direct 340B recipients go get their medicines. The vast majority of the activity has to be identifying well-insured patients and using those patients to generate a discount, which then goes into this pile of profits, and some of which makes its way to patients and some of which it doesn't. And I think the way G laid it out was very, very good, which is, what is the ROI here? Is this an efficient way, to do this? And so while it's easy to find examples of patients being helped, certainly within the grantees, certainly within the hospitals that are the covered entities, you can find lots of examples. But it comes at the expense of a really big program that is not well understood by anybody, really, and that certainly creates a lot of inefficiency in terms of how to support is going to patients. If you are to believe my numbers, maybe as much as 3/4 of the benefits here aren't making their way directly to patients. And so, yes, there's some patient help, but at the cost of a tremendous amount of inefficiency, and something that policymakers, I'm sure, have an interest in improving that efficiency. And I think certainly the last thing I'll say about the contract pharmacies is that it is extremely opaque how those relationships work. But I have a suspicion that in many cases, in some cases, you have very large, very profitable hospitals like the ones Ted has been talking about, where they can probably dictate terms with those contract pharmacies pretty effectively. But I think you have a lot of other hospitals, and especially a lot of grantees, who are probably at the mercy of those large contract pharmacy chains, which may be using that advantage to garner a greater and greater share of these profits. And I don't think that's what anybody really intends, is for the contract pharmacies to use that as an important profit source. And again, with more transparency, we would have a much better idea of what's going on there, because we really don't know what's happening other than through these indirect methods like mine.
Thank you. Ted, would you like to weigh in on how the increase in contract pharmacy arrangements has impacted your members and their patients?
Well, what it's done is that the problem is, again, who is getting the benefit of the discount here? And I'll tell you, when you look at some of the top contract, who are the top contract pharmacies? So look at who are the contract top pharmacies. It's CVS, it's Walgreens, Express Scripts, Optum Rx, and Walmart. 3 out of those 5 are the top PBMs that control 80% of the prescription drug market. Okay, so about 5 weeks ago or so, CVS released their earnings for last year, their 10K. And when you look at that, they, for the first time, put a disclaimer that said that because there are 16 pharmaceutical manufacturers that have stopped selling to multiple contract pharmacies, and I want to come back to that real fast, is that if that goes through, and that's in the court system now being debated, and basically if this happens, that these companies and even other companies basically stop telling multiple contract pharmacies, it will have a material and adverse impact on all of CVS Health. So when you just look at that, you say, where is the benefit going? It's not going to patients as a pass-through or even a little bump up for literally supplying the drug in one of those CVS pharmacies. It's going to the entity. And when you look at CVS, that has a lot of retail pharmacies, that's one thing. When you look at Express Scripts and Optum Rx, that basically has mail order specialty pharmacies, it just shows you how out of control this is. And I'll tell you another thing. I woke up today to an email from somebody who sent me a job description on LinkedIn from Optum for the director of 340B business opportunities. I literally tweeted it. So anybody who goes up, sees me on Twitter, can go look at literally the job description on 340B business opportunities. This is not about patients. And one thing I want to say, Jeanette, out there, is that I know, and I hear it from, FKHCs and Ryan White, AIDS. I mean, you go right down the federal grantees, and some of them are saying, this is an abomination. Why are these drug companies stop selling to multiple contract pharmacies? It's because the large hospital systems that Neil and Guy have been talking about have literally dragged down, and literally those federal grantees are being held hostage to these large hospital systems that, along with the PBMs, are literally printing money off of 340B. And it's not the patients, it's not the cancer patients and other patients that basically are getting the benefit, it's the institution. And that's why I'll tell you, and I tell every federal grantee I ever talk to say, oh, you're against the 340B program. No, I'm not. It's a program that should put discounts, serious discounts, into patients' hands. But the fact of the matter, they're being dragged down now by the PBMs and also the large health systems.
Thank you, Ted. So I'm going to let G weigh in here. So Neil's white paper shows that hospitals using contract pharmacies are disproportionately larger, right? So based on your research into hospital systems, why is this the case?
Thank you, Janet. Usually the large hospitals are well connected politically and they're more sophisticated in their operations, right? They're quicker and clever in identifying profit-making opportunities. And I think this might be what's going on here. Although I have never directly conducted research in 340B area, but in general, I think that is what's going on. And also I wanna add that, look, there's a target population, there's a untargeted population, right? Target population is the vulnerable patients that this 340B program is trying to help. And from Neil's report, no, there's no difference in charity care provision. And then look at the untargeted population, which Ted already mentioned, right? Look at the price offered to the well-insured patients. There's no study, to my knowledge, that show the 340B programs offer lower price to the well-insured patients. So therefore, overall, if we look at 340B as a vehicle to deliver value to all patients, clearly there's no such evidence. Thank you.
Yeah, awesome. Thank you. Okay, so this is a question for everyone. And we might start with Ted. So could each of you share your perspective on market distortions caused by the 340B program? And Ted, in your case, what do your members experience?
Well, Jeanette, it's tremendous consolidation. We've put out a report, every couple of years, literally showing the consolidation in, especially consolidation in the hospital systems. And I can tell you, I don't know if a week goes by where I don't hear from an independent practice, and I'm talking about even very large practices, where the hospital system has basically gone after them, wanted to basically incorporate them, buy them out, or said, we'll put you out of business and we'll run our own cancer center. Why? Because they make so much money off of drugs specifically discounted by 340B. In fact, if you look at that JAMA paper that I referenced, there are 71 NCI designated cancer centers. Not all of them provided the data as they are required by law and regulation, but the ones that the JAMA authors looked at, the studies in the authors of the JAMA study, basically, we looked at those, and 3/4 of all NCI designated cancer centers are 340B. So this is a real problem, because what it's done, it's created consolidation. What happens consolidation? You get all of a sudden, basically, a 340B hospital buys an independent practice. Patient comes in, let's say from the 3rd cycle to the 4th cycle, they're getting the exact same chemo from the same nurse, the same name is on the door, the same doctor, the same drugs, everything. And then basically they get their EOB, their bills, and they can't believe what it's costing them in terms of what their out of pocket is. And that's because the hospitals charge so much more, not just for the drugs, but cancer care in general. So what's happened is the 340B has been a mechanism to consolidate practices, obviously consolidate hospitals, big hospitals buying up small hospitals. And what this has done is ratchet up prices. And if you look at the data, in terms of on the commercial market, you look at the Medicare Part B, you look at the data, and you see basically what's happened, and it's happened because consolidation. So how does that affect cancer patients? Cancer patients pay more for their care. Yes, when you talk about drugs, underlying responsibility starts with the pharmaceutical companies. But when you have hospitals making more money off of drugs than the companies that are actually manufacturing them, you say something is totally out of whack here. And especially in a time now when we see the inflation rate, we see the pressure on people coming out of COVID, we see a high inflation rate, and people cannot afford their care. And so when they go to an institution where they're not getting the benefit of that 340B discount, if ever is in need, it's now, but they're paying more for their care, something's out of whack.
Awesome, thank you. I'd like to turn to Ted next. So Neil next. Can you talk a little bit about the 340B cost implications on the healthcare system as a whole?
Well, I think a lot of what Ted just said, actually, that's the part that's hardest to measure, because there's a lot of steps between consolidation, and then it takes a little while, and then the prices start to go up. maybe not in every case, but we see that we all see that in our insurance premiums. And now 340B is only one of a number of factors, probably a really big factor for oncology, but there's a lot of things that drive consolidation. I do think 340B is an important consideration there and worth studying more. The second piece is this sort of interplay with Medicaid, which is interesting. You're seeing that food fight play out now in some of the states that have sort of gone back to fee-for-service on their drugs because they've realized that foregoing the discounts for 340B, foregoing the discounts by letting the managed care companies, the Medicaid managed care companies capture them, is costing them, hundreds of millions of dollars, which is a significant amount, obviously. And I think all of the states right now have been feeling really flush with all the COVID relief, but I think they're all eyeing what's going to happen when those redeterminations start and how fast that's going to go and what's going to happen to their Medicaid populations. It's like it all sets up for like a little, I'm worried about the chaos of the transition out of the PHE, the public health emergency, in terms of Medicaid. And this is one of the many moving parts. And I think states are going to increasingly look to that. And one of the frustrations, I think, is like if I'm a grantee or a hospital and I've come to rely on this profit in such a meaningful way to fund my operations, I don't think that's really the way you want to run the railroad. This is sort of a Rube Goldberg sort of mechanism that does lead to amount of money going in to fund these important programs. But it seems like, just as an economist, again, looking at it, it does not seem particularly efficient, and nor does it seem clear. And one of the things you really value as a business person is just clarity of the rules. And so you've got all of this kind of uncertainty that's built up around this program that I think is making everybody frustrated and should bring everybody to the table to try to improve that program in ways that other people will have much better ideas than I do. But I think those indirect Medicaid costs are just an illustration of some of the pressures in both directions that we see from this convoluted program.
Thanks, Neil. And so, Dr. Bai, I'd love for you to weigh in on your expertise with the cost implications for taxpayers.
Thank you. So there's a direct effect, as Neil mentioned, that's benefiting hospitals, as the report shows, but there's a ripple effect, as Ted mentioned as well. The consolidation, now many people are talking about consolidation, right? But 340B is really underexplored, under-recognized reason. So if we are barking on the wrong tree, then no matter how much DOJ is putting effort to prevent antitrust issue, we still have a strong incentive underneath hospitals and small providers trying to consolidate to take advantage of the 340B program. So I think without addressing the 340B distortion on the market, the consolidation trend won't really be mitigated. And also, I following the efficiency argument, think about the intention of the program. If the program is really trying to help the vulnerable patients, then there are much better ways. Let's look at the direct pool, right? Put the money, directly help the patients without changing hands through hospitals. Would that be more efficient? I would think so, right? Or if you really want to use hospitals as a vehicle to give the money to them and then let them help the patient, then you might want to make a better connection between who they helped, like how many Medicaid patients they helped, how many charity care, how many underinsured patients they helped, and then link that to the 340B program. I think either we, the first best would be just have a direct contribution, to the patients, or the indirect way, at least make more disconnection between the recipient and the 340B revenue. I think would be a better way to make the system more efficient.
Okay, thank you. Sorry, I had to go off camera for a second. So before we turn to the to the participant Q&A, we do have two great questions come in. I want to just maybe round out our talk by getting your thoughts on what can be done to ensure the 340B program is fulfilling its mission to help underserved and vulnerable patients. So let's see. Ted, do you want to take it? And probably this.
Yeah, I'd say it's very
focusing on
simple. Federal grantees are held to literally transparency and accountability. The problem here is not on the federal grantee side. The problem here is on the hospital side. And the hospitals, there is a complete black hole. There is no transparency. There is no accountability. And I don't care what anybody says, what kind of reports they have to file. There is nothing that compares to federal grantees. So number one, literally transparency and accountability. And if I'm an FQHC or I'm in one of the federal grantees, I'll tell you, because this program is going to come under increasing attack. It's like a financial bubble that will burst. If I'm a federal grantee, then I push for accountability and transparency on the hospital side, number one. Number two, I can tell you right now that we're working on legislation with members of Congress where the discount would follow the patient in the hospital side. Okay, so it's not on the federal grantees, not even children's hospitals, but basically in your dish hospitals, literally the discount should follow the patient. And that way we know the discount is following the patient. And without any transparency or accountability or anything that basically governs and puts guardrails on where the hospitals are putting this money, then you're going to see an expansion of 340B in the hospital side and specifically on the contract pharmacy side, depending on the outcome of the litigation that's going on now with pharmaceutical companies and some of the hospitals and HHS and all that in terms of curbing sales to multiple contract pharmacies.
Thank you, Neil.
Yeah, I mean, so, I'm not here to necessarily make policy recommendations. I'm analyzing the data and trying to piece together what's going on with this program. I think that to me, just as someone trying to analyze it, you run into a lot of, it's very hard. You wind up relying on indirect measures and other things because of that lack of transparency that Ted, and that's not necessarily from bad intentions that there's no transparency. It's more like if you don't require a certain degree of consistent reporting about the kinds of activities that you're hoping to see, then you're just not going to get it. So even if you try to study this across grantees, for example, with all their, with all best intentions, when they each file a cost report or a Form 990, they all look very different. So when you're trying to analyze what's going on in a systematic way, it's very, very challenging. And, I've beaten my head against the wall many a day trying to, piece together a consistent look and way to compare apples to apples across this program. So I would say if I'm a policymaker, selfishly, I'd love to see more transparent sets of data around the activities and compare those activities to what policymakers intend, whether it's patient help or whatever it else, and also compare it to the implicit cost of that, to the not just to the drug companies who are the obvious funders, but to the taxpayers who are the indirect funders that are significant funders. And by taxpayers, I also mean people who pay for their health insurance premiums, because I do think that this bleeds through to our premiums in some regards. And so I think that, this is going to be an ongoing debate. As Ted said, there's a lot of litigation going on and who knows where that's all going to wind up. But no matter where it goes, it's clearly, nobody's talking about pulling the plug on this program. And the idea is to make the program work the way it's intended, to get the maximum amount to the patients, I would imagine. And I don't think that's what's happening now. So, I would start with better data and more transparent data, and maybe even incentivizing the people in the program to provide that data in some way. It doesn't have to be all, requirements. If I'm a grantee somewhere or a little rural hospital, if you tell me I have to report 50 more things, it's a lot of burden, but you can incentivize people appropriately to provide that good data so that we geeks can analyze it appropriately.
Absolutely. Thank you. And we'll give Dr. Bai a moment to weigh in.
Yeah, thank you. So if you think from the hospital perspective, assuming, as many have already accepted, that 340B program is a very profitable investment from hospital perspective, then hospital won't stop. They will keep exploiting, and small hospitals are going to learn and they're going to apply. And so I don't think without any policy change, the trend of the expanding 340B program revenue would decelerate in the near future. We'll see this problem keep become bigger and bigger. So I think it really has to go to policymakers, up to them to make a change. So in my opinion, it's really straightforward. Just put your eligibility criteria and the payment, the payment amount, all linked to the target population. That's it, right? Who's your target population? The underinsured, the uninsured, the people who are eligible for charity care, etc. So if you make the good link together and then make it transparency, and then we'll have a good accountability, and this program's outcome will be better aligned with this intention. Thank you.
Thank you. Well, we have a great question. We're going to turn it now to the audience. We have time for a few questions. So folks have been dutifully putting their questions in the Q&A function, which you can find at the bottom of your screen. And I'm going to ask the first one. A question's come in and it says, a number of you have raised concerns about a lack of transparency in 340B. CMS recently implemented hospital transparency regulations, which has been the effect. What has been the effect of those regulations on accountability for hospitals? And has it had an effect on transparency in how 340B funds are used?
Well, I can get rid of it. I know, Ted, you're chomping at the bit on that one because I know you've actually done work trying to use the results of that rule. I would just, as a policy person, say it's early days in terms of reporting transparency. That would be the kind way to put it. Most hospitals are I don't think anything close to the majority of hospitals are actually reporting the price data that you would need. I don't know what the percentage is. It was like 30 or 40% or something, because the penalty is, so minimal, $300 a day. So, there's not a lot of reporting yet. I do think that it will get there. I think that if you give it a couple of years, perhaps we'll start to see more of that data in a usable format. So that was my neutral, my desire is to see as much of that data as humanly possible. It is not easy to access any of that data. So, I think that's my 2 cents, but Ted, you probably both have looked at it more than.
Well, I will just tell you that the numbers are very low. There are more hospitals putting up the data. Go in and try to find the data on your hospital. Go in and try to find and read the data in any accessible form of your hospital. In fact, we're coming out with a 2.0 version of this study that we released last year. It'll probably be at about in a month or so. And it's even harder to get at some of the data that now is being released. So hospitals are dragging on this. They're not making it easy. There was a story in the Wall Street Journal last year as the Wall Street Journal looked into this and basically found out that even the hospitals that were reporting their data were embedding code so that basically you couldn't find that data by going in and Google it. So this is something that is really, it is so revealing when you see this. I just took a look. I just had a look this weekend. I worked on it for a couple hours looking at some preliminary data out of our 2.0 report, and it's striking. It shows how much hospitals, especially 340B hospitals, are making on drugs. And I saw a comment by someone who was anonymous and very obviously a 340B supporter, and basically said, shouldn't hospitals make money on drugs? Well, they shouldn't make money in some cases at marking up drugs 3.8 cancer drugs on a median, an average 3.8 times. It's inexcusable. So this data is hard to get to. We're seeing more hospitals, a little couple come to the fray, but at a penalty of $300 a day, that a big hospital will gladly pay the $300 a day. In fact, I believe big hospitals will pay a couple $1 million a year just not to have to put their data up.
Thank you. Dr. Bai, would you like to weigh in on this question?
Sure, thank you, Janet. So even if, let's say, we have the perfectly accessible data, still there's no information regarding how much benefit the hospital got for us 340B program, right? The current transparency regulations only about negotiate the commercial price, cash price, the charge. So I think that will give us circumstantial evidence, but not really direct evidence.
Okay, great. Well, we basically have come up on time here. It's now 4:30. I wanted to thank everyone for joining us today. We will post a recording of today's session on our website. So thank you so much for this discussion. And we'll put all these resources up and try to also publish that JAMA article you mentioned, Ted, and make that available to folks as well. So thank you all. And with that, we'll conclude today's briefing. Thank you.
Thank you.
Janet.
Thanks very much.